Hello everyone, my name is Beaudet, and today I am presenting my Global Mental Health Final Project on post-disaster mental health, specifically access to care while rebuilding from disaster. Due to the nature of their development, lower and middle income countries tend to be impacted harder by natural disasters. This is partially due to their lack of infrastructure when compared to higher income countries. And this specifically can be seen through healthcare infrastructure and that of mental health care infrastructure. The situations are then exacerbated by the new influx of mental illness that is seen in post-disaster situations. Surveys conducted by the WHO have shown that there's an increase in prevalence of severe disorder, mild or moderate disorder, and even normal distress up to 12 months after a disaster has occurred. There's also multiple studies that have showed the increase in mental health illness is longer lasting. For example, about 2 years after the Chai Taiwan earthquake of 1999, the estimated rates of PTSD and psychiatric morbidity were 20.9% and 39.8% respectively. This highlights that there is a great need for access to appropriate mental health care years after disasters occur, and not just in acute situations. Without appropriate access to mental health care, individuals will suffer. My main research aim was to analyze access to mental health care in post-disaster settings. As I began researching, I started to notice recurring models and recommendations that were modified based on the context of the disaster setting. So within my presentation, I'm going to address some psychological and social contextual pieces that must be considered to understand access needs, explore the main models for mental health treatment in post-disaster settings and developing countries, and then present a few examples from countries where these models were implemented to increase care access. My ultimate goal here is to provide an overview of some of the researched approaches to increasing access to care in these settings, and through this highlight some key strategies that can be used for future disaster preparedness planning and general treatment within low and middle income countries. When gathering information for my presentation, I used PubMed database, Google Scholar, and Google. For all of the databases, I used the key terms of global mental health, post-disaster, and treatment. And I also tried to keep the publication year from 2000 onward. There is kind of a limited amount of resources available and different studies available for this topic, so I tried to keep that publication year a little bit broad without going below the year 2000, and all the papers I used were in English. I first want to start with post-disaster context. In most papers that I read, they address that different communities have different needs, and this greatly shapes their recovery. In their 2007 published Guidelines on Mental Health and Psychosocial Support in Emergency Settings, the Interagency Standing Committee provided 7 different considerations that must be addressed when dealing with mental health recovery in a post-disaster setting. When we think about these interventions and their successes, the more a community and their needs are directly addressed, the better fitting that intervention is going to be, especially when considering access to care. So throughout the literature, and as I will show you later in this presentation, the access interventions that value context and work within it have shown both short and long-term changes for their communities. And so some examples of these different considerations are for pre-existing social problems, extreme poverty, belonging to a group that's discriminated against or marginalized, for emergency-induced social problems. That includes family separation, disruption of social networks and community structures, For emergency-induced distress, that includes grief, anticipated or non-pathological distress, and distress in which the symptoms may appear similar to those of acute distress disorder. For emergency-induced mental disorders, that includes depression and anxiety, PTSD would also fall under there, or substance misuse. And then there's humanitarian aid social problems, and then below that, psychological problems. So for the social problems, that includes the undermining of the community structure or traditional supports. And for the psychological problems, that includes the anxiety or the disruption that happens from poor management of all of those resources. So it's important to consider that humanitarian aid itself could cause contextual problems or conflicts and increase mental disorder within the communities that are trying to recover. And then for pre-existing mental health or psychiatric problems, that includes, severe mental disorders, alcohol abuse, etc., as we listed with the background. So all of that information is really, really important to understand in order to then develop an access care plan or a policy moving forward that really addresses what the community needs. In addition to understanding the context of the post-disaster situation, it's also important to understand the actual services that are needed. And so this is where the model section of my research kind of comes in. And this is an image of the optimal mix of different mental health services that are defined by the WHO. We also saw this in our Sorrell textbook, but I knew it was important to bring back again because it is a model that is used globally to kind of depict what the optimal mixture of services should look like. And so this model is based on the principle that no single service level can meet all the population's mental health needs. Self-care, informal community care, and primary mental health care form the base of the model. These are where the majority of care should be located, but for many developing countries, it's not. In fact, it's actually the specialist services and the special mental health clinics that provide most of the care in these countries. And for those requiring more intensive services at some point in their lives, outpatient and short stay inpatient care should be available through secondary care, and that should only be a teeny fraction of those with severe mental health disorders that will require long stay services. So again, those should not be used for every mental health problem, but in developing countries right now they are. And across all levels, the model emphasizes that people with mental health problems need to be involved in self-management of their condition. Clear referral, back referral, and linkage systems are needed to connect health care workers with all service levels and with all sectors. So again, clear communication from the top down and the down to top are really, really important to having a efficient and connected mental health care system. And so this base model is really used as a guide for a lot of different other models that we're going to see, and then I'm going to present in the next couple of slides two other different models that use this as a base to post-disaster mental health planning. And this is the first emergency response model, which is based off the WHO model. And this is developed by the Interagency Standing Committee and the Sphere Handbook, and it provides a consensus-based guidance and standards on mental health services and community psychosocial support during emergencies, including early recovery. This pyramid is consistent with available evidence and stresses that emergency-affected people need different types of support. A layered set of supports is depicted in the form of the pyramid that we can see here, and the pyramid is of services that become more focused, specialized, and costly towards the tip of the pyramid. Collectively, though, the support layers aim to meet the needs of different people in a complementary manner. Important in their own right, the layers of support recommended by the Interagency Standing Committee in Sphere and emergency settings can become the basis for developing mental health care after emergencies. And just taking a look at those examples, you can see different actions that humanitarian workers or government employees could look at for developing acute policy, but then also framing their more long-term plans, because short-term or long-term, each of these layers is going to be needed in emergency disaster situations. And this is a second emergency response model that I found in the literature. And this model uses different levels to break down the services that are needed by a community in a post-disaster situation. So starting with, psychological first aid, all the way down to psychosocial interventions for medium and long-term problems. So this model breaks it down by different layers, and those layers have similar themes to the layers that we see in the pyramid. But the important point here is that, again, there's multiple levels, multiple different platforms of services that are needed by these communities in order for them to have successful access to care. So you can't just have one and call that a successful system. You need to be able to provide services to people throughout their communities and over a long term. Fixing the acute problems right after a disaster, yes, are very important, but increasing longevity of the mental health services that are allowed and available to the communities is what's really going to create a more sustained and well-developed mental health approach for that country and community. So when thinking about the models that were just presented, they have different layers to the services that need to be provided in order to have a complete picture of mental health care for a community. So when access to each of those levels or interventions at each of those levels are not provided for a community, that's where we can have unbalanced mental health care and people aren't getting the treatments that they need. And this is happens more often, especially in disaster situations, but more often in lower and middle income countries as well. And so these next three examples from Indonesia, Sri Lanka, and Jordan are all going to show situations where they increase access to care when their levels of access had been damaged or prevented by disaster situations. So this first access to care intervention comes from Indonesia in the province of Aceh, and this is happening in the wake of the 2004 tsunami. So before the tsunami, the healthcare system here was very centralized. There was only one mental hospital that was located in the capital city of the province, with one part-time and two full-time psychiatrists, 120 beds that were always at max capacity, and the secondary and primary healthcare centers that were scattered throughout the province were very limited in their capacity to provide mental health services. So after the disaster strikes, there was an influx of people with mental health issues, and so the government knew that they needed to step up and make a change here. And with the help of the WHO and the Ministry of Health for Indonesia, they created a program that trained nurses to deliver mental health care. So within this model, nurses conducted home visits to ensure that people with mental disorders received appropriate medication and provide support to their families, and when needed, they would refer people to acute inpatient centers. So initially, this training took place in 11 of the most affected districts, and 10 primary health care centers were selected, each of which chose 2 nurses for training. So there was a total of 220 nurses that ended up participating. And since that original launch of the program, every single district within that province has at least some capacity to deliver mental health services at a primary care level within their centers and through these trained nurses. So it was extremely successful for them because now they went from having very limited care with one hospital to having every district be able to provide some level of mental health care for their citizens. This really shows the importance of decentralizing care and building on that base of the triangle. So the more you involve the community and allow people to be self-involved and improve their self-care through these decentralization processes, the more successful your mental health system is going to be. So this second access to care intervention comes from Sri Lanka, and this is a very similar situation to the previous one in Indonesia, where prior to the 2004 tsunami, most of the mental health services were provided through tertiary level hospitals in major cities, mainly near the capital of Colombo. Trained mental health workers were scarce in other parts of the country, so which meant most people with mental health needs failed to receive any kind of treatment. And so in the wake of the disaster, a presidential task force actually was established to provide support for mental health relief. And they initially dealt with a lot of the acute situations, but then realized that beyond that acute situation, they had a lasting problem here they needed to address. So in 2005, they enacted a new policy that emphasizes comprehensive, decentralized, and community-based care. And it calls for a reconfiguration of their mental health services that they provided to be as locally accessible as possible. And so through that, every district is required to establish acute inpatient wards, as well as a broad range of community-based services, including fixed and mobile outpatient care and community support centers, with referral up and down to different levels of care. So again, this is really highlighting the use of that pyramid model of showing that, yes, you can have those clinical centers, but you need the local base layers. You need people to be in charge of their self-care in order to be more efficient in providing mental health. And this is extremely important when you're rebuilding your infrastructure after a disaster situation. So as of 2011, 20 out of the 26 health districts had functioning acute inpatient units with general hospital setting, and compared with 10 out of 26, which is what they had before the tsunami. So they had, 10 more health districts that had functioning general hospitals that could provide mental health care for their citizens. And if you look at the pictures up here, it shows the yellow being very basic mental health care services. The kind of brownish yellowish color is basic mental health care services, and the maroon is comprehensive services. So over time, from 2004 to 2012, the amount of comprehensive mental health services available to these citizens grew greatly. This final access to care intervention example comes from Jordan. And after an influx of refugees in 2007, they realized that their centralized psychiatric hospitals and mental health programs within these hospitals was being overwhelmed by the amount of people that needed treatment. So the government realized we need to come up with a new solution that is less central, just like in the other two countries, that's able to meet individuals where they are, especially because of the high refugee populations. There's more diversity and more cultural diversity within the country. And so they developed, they being the government and, of course, the Ministry of Health in Jordan and the WHO, worked together to develop community mental health centers. So these are designed to provide comprehensive biopsychosocial services and the environment that respects people's dignity and protects their human rights. They are run by multiple disciplinary teams that are assigned to each clinic. Members of each team include a senior psychiatrist, a resident psychiatrist, a psychologist, a nurse, a social worker, and an occupational therapist. And so these centers provide a wide range of services, including medical treatment, psychological interventions, social assistance, rehabilitation services, psychoeducation for people with mental disorders and their families, home visits, and awareness-raising activities in the community. So these clinics and centers really provide comprehensive care and building on those bottom two levels of the mental health services triangle. And so from 2009 to 2011, 3,550 service users received biopsychosocial treatment with an individual treatment plan. So they were able to reach, almost 4,000 citizens just by having these three clinics that could go out and affect change within their communities. And this graph that you see is showing the number of non-psychiatrists receiving mental health training since 2008. So as you can see, pre-2008, there was nobody besides psychiatrists being trained to help with mental health services. And then after 2008, there's such a large number of secondary care workers, primary care workers, and service users that were having this training. So again, we could disseminate mental health services throughout these communities and decentralize it. In conclusion, we can see that in post-disaster settings, mental health care needs to be easily accessed. And in order to do that, mental health services have to be available at multiple levels, not just at a clinical setting in a hospital or a psychiatric hospital within a big city. They have to be community-based and decentralized as well. And these services need to empower community members to increase their access as well. So services that increase access include ones that are decentralized, community-based centers that are allowing for educational opportunities, and for family training and planning in order to be successful more long-term. Additionally, these access interventions are looking at the context and the culture of the local communities or districts in order to provide interventions that are tailored to the needs of those individuals. Please follow the link provided if you'd like to see more examples from the field from different countries as they build back from their disasters.